A Multifaceted Approach to Improve Antidepressant Adherence by Jessica Duncan. This presentation will look at EBP recommendation for the treatment of depression in adults, specifically the best treatment to improve antidepressant medication compliance. As a future psych nurse practitioner, I'm very passionate about finding the best evidence-based treatments available to my patients. First, I would like to share some facts about depression. Depression is one of the most common mental disorders in the United States and is the leading cause of disability worldwide. An estimated 66% of U.S. adults received treatment for their depression in 2020. Depression increases the risk for diabetes, heart disease, strokes, as well as many other physical health problems, whereas chronic physical disease can also lead to depression. Depression contributes to over 11% of emergency department visits and over 10% of all physician office visits. Depression is one of the most common chronic conditions seen in general medical practice, second only to hypertension, with over half of all depressed patients seen only by their primary care providers. Deficiencies in depression management are a major health policy concern with a high public health impact. One of the most critical issues related to depression treatment is poor adherence to antidepressant medications, which contributes to poor response, relapses, increased morbidity, comorbidity, death, and increased healthcare cost. Of those who receive an antidepressant prescription, over half discontinue treatment during the first month, and up to 68% discontinue treatment within 3 months after the start of treatment. It is estimated that less than 40% of patients diagnosed with depression take their medications appropriately. Since poor antidepressant adherence is a major contributing factor in inadequate treatment of depression and leads to many consequences and life-threatening outcomes, it is extremely important for clinicians who prescribe antidepressants to seek out and focus their efforts on treating this condition with the same effort as any other life-threatening illness. For my practice problem, it is due to the complex nature of depression and the varied reasons for non-adherence to medications. It's crucial to find the most effective interventions to help improve adherence to antidepressant medications for those suffering with depression. My PICO statement is, or question, in adult patients with major depression, is the use of collaborative, multifaceted interventions more effective than medication education alone in antidepressant medication adherence? This multifaceted approach will help address some of the most common reasons behind non-adherence, including patient factors such as concerns about side effects, fears of addiction, the stigma associated with mental illness, and the belief that the medications will not address their problems, as well as clinician factors such as a lack of sufficient patient education, poor communication, and poor follow-up. Individual components of a multifaceted intervention should include educational, behavioral, effective, and provider-targeted strategies, with care management and patient follow-up a central theme. For my project, a literature search was conducted using Medline, PubMed, Google Scholar, and the Sentinel databases. The search was limited to full text available primary research studies and systematic reviews in the English language that were published in a peer-reviewed journal. Keywords and medical subject headings used to identify relevant studies were depression, depressive disorder, medication compliance, medication adherence, antidepressant compliance, antidepressant adherence, antidepressant, intervention, treatment, management, and strategies. The reference list from the included studies were also searched for relevant articles. The studies included were 5 RCTs from the United States and 1 systematic review, in which most studies were reviewed from the United States. A synthesis of the literature relative to the PICO statement identified 4 major themes. The first theme was that multifaceted interventions are more effective in improving antidepressant interventions than education or usual care alone, with the most successful using a combination of educational, behavioral, affective, and provider-targeted strategies addressing research-identified barriers to treatments. A collaborative care approach was the second theme that showed an improvement to medication adherence. The most successful interventions for improving antidepressant adherence included the collaboration of primary care physicians, mental health specialists, and other allied care professionals, and of course the patients. The third theme was that interventions must be individualized and able to address the multiple barriers to antidepressant treatment in a patient-centered manner, reflecting the multifactorial nature of non-adherence. And finally, ongoing frequent follow-up results in better antidepressant adherence. The setting for my recommended change includes primary care clinics and mental health care clinics. Primary care clinics are a common place for the treatment of depression among adults, especially adults with comorbidities. The integration of mental health services into primary care helps facilitate access to psychotherapies, proven effective, and other evidence-based multifaceted approaches. The ARCC model, advancing research and clinical practice through close collaboration, can be used to implement this proposed evidence-based practice change. First, the culture and readiness of the practices must be assessed for implementation. Next, facilitators and barriers to the EBP process must be identified, such as a lack of mentors and knowledge of the EBP process and skills. Third, mentors must be identified who have extensive knowledge and positive attitudes regarding the EBP process, who are able to encourage and motivate staff beliefs about the values of EBP change and their ability to implement it. Advanced practice nurses, clinical leaders, and nurse managers would be mentors in the primary care and mental health care settings. And then fourth, the recommended intervention could be implemented into practice, and then the outcomes could be evaluated. The EBP implementation can be evaluated in several different ways. First, the culture and belief of EBP can be evaluated. At the start of the EBP project, through use of the ARCC mentors and model, staff will be given the organizational culture and readiness for system-wide implementation of EBP scale and the EBP belief scale, as well as the job satisfaction survey. These surveys will be retaken after the implementation of the EBP project, and the results can be compared. The OCR SIEB scale is a 25-item scale that measures organizational culture and readiness for system-wide integration of evidence-based practice. The EBP scale is comprised of 16 items that an individual's belief about the value of EBP and their ability to implement it. After an effective mentor these values will improve. Healthcare satisfaction or healthcare provider satisfaction scores should also improve after feeling supported and improving their knowledge and attitudes towards EBP. These measures will evaluate the effectiveness of the use of the ARCC model in the implementation of our project. Next, the EBP intervention itself can be evaluated by looking at patient outcomes such as medication adherence rates, depression outcomes, and patient satisfaction. These outcomes post-implementation can be compared to evaluate the effectiveness of the implemented change. For our PICO outcome of medication adherence, there is no gold standard in measuring adherence, and due to a lack of standardization of terminologies and definitions in adherence research. Asking patients about adherence and verifying with a refill request would be the best way to record adherence outcomes. Depression scales can also be compared and recorded before and after implementation. Patient satisfaction scores have also been noted to improve through more patient-centered care, follow-up, and increased adherence to medications. Depression outcomes, satisfaction scores, and adherence are all outcomes that have been found to be linked together. Once outcomes are reviewed, they can be shared with all stakeholders. The barriers and facilitators can be discussed, and any recommended changes or improvements can be discussed and implemented. The team can continue to work together on improving this specific project and then others. After the first EBP project is implemented successfully, confidence will grow and further EBP practices can be implemented. In conclusion, depression is the leading cause of disability worldwide. There is a critical and urgent need to improve upon antidepressant adherence in adults suffering from a major depressive disorder. Non-adherence to antidepressant therapy is a major problem in the management of depression and is caused by many varied factors. Evidence shows that a collaborative, patient-centered, multifaceted approach to treatment is more effective at improving medication adherence than education alone. Primary care clinics and mental health care clinics must collaborate in order to provide the most effective evidence-based care. This evidence-based intervention can be implemented through the use of ARCC model as described. Outcomes can then be measured, and once effective implementation is completed, there will be more confidence in EBP, provider satisfaction will be increased, and most importantly, patient outcomes improved. And thank you for your time.